Bupropion, norepinephrine, dopamine, and a different profile. Bupropion is one of the psychiatric medications where the nickname can be helpful and misleading at the same time. People call it the non-SSRI antidepressant or the energizing antidepressant. Those phrases point to something real, but they are not enough to understand the medication safely. This video is a structured overview. What bupropion is, what it treats, how it works, what people commonly notice, side effects, serious cautions, monitoring, interactions, and how it differs from similar options. Bupropion is an atypical antidepressant. Atypical means it does not fit neatly into the SSRI or SNRI categories. In the United States, Wellbutrin XL is labeled for major depressive disorder and prevention of seasonal affective disorder. Bupropion sustained-release products are also used for smoking cessation. Different products and formulations do not all have the same labeling, so the formulation matters. Mechanistically, bupropion is usually taught as a norepinephrine dopamine reuptake inhibitor. Reuptake is a recycling process. After a chemical signal crosses between neurons, transporter proteins help pull it back. Bupropion and its active metabolites affect norepinephrine and dopamine transporters, with minimal direct serotonin effect. The exact therapeutic mechanism in depression is still not fully defined, so this is a teaching model, not the whole biology of mood. That norepinephrine dopamine profile helps explain why bupropion can feel different from many serotonergic antidepressants. Some patients notice improved energy, concentration, interest, or reduced nicotine craving. Some notice less sedation or less sexual dysfunction than they experienced with an SSRI, and bupropion is generally considered weight neutral or weight negative rather than weight positive. But none of those are guaranteed. Some people feel no benefit, and some feel worse in specific ways. Common side effects fit that activating profile: dry mouth, nausea, insomnia, headache or dizziness, sweating, tremor, anxiety, agitation, palpitations, appetite changes, weight loss, and rash can occur. Insomnia is especially important because a medication that feels alerting during the day can be very unwelcome at night. Anxiety is also individual. For one person, depression improves and anxiety settles. For another, activation feels like jitteriness or panic. The serious cautions are the part that should never be reduced to a nickname. Bupropion can increase seizure risk, and the risk is related to dose, formulation, patient factors, and interacting substances or medications. It is contraindicated in people with a seizure disorder, and in people with current or prior bulimia or anorexia nervosa. Abrupt discontinuation of alcohol, benzodiazepines, barbiturates, or anti-epileptic drugs is also a major label contraindication. Like other antidepressants, bupropion carries a boxed warning about increased suicidal thoughts and behaviors in children, adolescents, and young adults. This warning is not unique to bupropion. It is part of the broader antidepressant safety labeling. Clinicians also screen for bipolar disorder because antidepressants can activate mania or hypomania. Bupropion is often considered lower risk for mood switching than some serotonergic antidepressants, but lower risk is not zero risk. Other cautions include elevated blood pressure, neuropsychiatric symptoms, angle closure glaucoma risk, and rare but serious allergic reactions. Monitoring is mostly clinical, not a routine blood level test. Blood pressure should be assessed before treatment and periodically during treatment. Mood, suicidality, sleep, anxiety, agitation, manic symptoms, seizure risk factors, alcohol or sedative use, and medication interactions all matter. The interaction list is clinically important. Bupropion is metabolized through CYP2B6, so some CYP2B6 inducers can lower exposure. Bupropion also inhibits CYP2D6, which can raise levels of several antidepressants, antipsychotics, beta blockers, and antiarrhythmic medications. MAOIs are contraindicated. Other medications that lower seizure threshold require caution. Dopaminergic medications can increase central nervous system side effects. Alcohol patterns matter, and people should not accidentally combine multiple bupropion-containing products. So how is bupropion different from similar options? Compared with SSRIs, it is less serotonin-focused and may be less associated with sexual dysfunction or sedation, while its weight profile is usually weight-neutral or weight-negative rather than weight-positive. Compared with SNRIs, it emphasizes dopamine and norepinephrine rather than serotonin and norepinephrine. Compared with sedating antidepressants, it is often less sedating, but can be more activating. Compared with stimulants, bupropion is not a stimulant and should not be treated as a simple focus booster. However, it is sometimes used off-label as a non-stimulant medication option for adult ADHD when clinically appropriate. For smoking cessation, bupropion is a real option, but the American Thoracic Society guideline recommends varenicline over bupropion when initiating tobacco dependence pharmacotherapy. The key takeaways are: bupropion is not an SSRI. Its teaching anchors are norepinephrine and dopamine. It can have a useful profile for some people, and it has its own safety issues. The right question is not whether bupropion is good or bad. The right question is whether its benefits, risks, interactions, and monitoring fit a specific person. This video is education, not medical advice. Medication decisions should be made with a licensed clinician who knows the full history.